Welcome to Medical Testimony Masterclass. I'm Arlin Crisco, and I'm here with Dr. Burton Bentley, CEO of Elite Medical Experts, and an expert himself on the presentation of medical evidence at trial. Dr. Bentley, how are you doing today?
Doing well, no complaints.
All right. I'm eager to jump into the case we have today. I think it's going to be a really interesting one. Here at Medical Testimony Masterclass, we like to provide a forum spotlighting some of the best medical presentation at trials that we've covered at CVN. And that's all with an eye toward helping you improve your own medical testimony presentation. We have a really interesting case today. It's actually a medical malpractice case that led to a defense verdict in California earlier this year. And while the medical procedure at the heart of the case isn't necessarily the most common, the issues surrounding the trial are issues that medical malpractice attorneys see all the time, among them informed consent and the limits of informed consent and how you argue an informed consent claim. Now, the lead defense attorney on the case was Louis DeHaas of La Follette, Johnson, DeHaas, Fessler, and Ames. He was defending a neurosurgeon, Dr. Mark Schwartz, who was accused of medical malpractice and civil medical battery by a plaintiff patient who'd contended that he'd suffered facial paralysis during a surgery for an acoustic neuroma. Now, that's a non-cancerous tumor running on the main nerve from the inner ear to the brain. And while it's non-cancerous, it is slow-growing, so it can lead to hearing loss and a host of other complications. Now, in the case, the plaintiff claims that the doctor didn't provide enough information for him to make a fully informed choice as to which treatment option to choose, and that the doctor botched the surgery and didn't stop the procedure when it was clear the facial nerve was being impacted. And Dr. Schwartz counters that he had provided enough information about the surgery, that actually this patient was really knowledgeable about the procedure. He'd done outside research and talked to other doctors. Dr. Schwartz also claims that he had followed the standard of care and that the nerve injury actually occurred outside the portion of the procedure that he'd been responsible for. Before we get to the main expert in this case for the defense, Dr. Bentley, could you tell me a little bit about what we should keep in mind with these informed consent cases?
There's a few things, and thank you for the introduction to that, because it's a complex case. And again, for everybody listening today, it's irrelevant that this involves a tumor called an acoustic neuroma or schwannoma. It doesn't matter. We'll talk about broader constructs and just use this case to illustrate informed consent, medical battery, how did that permeate this? So very quickly, for anyone to undertake surgery, they have to be properly informed and then have the right to either give or withhold their properly informed consent. So in many cases, there's an allegation, hey, I didn't really understand, I wasn't informed, or the paperwork wasn't done. So I think the key thing, because we'll get into that a bit with this case, is what is the standard for informed consent? And essentially, it means that a patient has to understand the contemplated procedure, has to understand the risks and benefits of that, needs to understand what are the alternatives, and that's one of the keys in this case, and then the risks and benefits of that alternative. And then with that whole amalgam of risks, benefits, and alternatives, has to be able to articulate why they either give or withhold their informed consent. So imagine someone's wildly intoxicated. I might tell them all those words, but they can't articulate back why they're allowing me to do something. So again, understanding the procedure, risk, benefits, and alternatives, and saying, yep, here's why I'm going to let you do it. So that would be compliant consent. Statutorily, it's there's a little bit of gray zone depending on what state you're in. Some states adhere to what we call a reasonable patient standard, meaning what would a reasonable patient want to know in order to give or withhold consent. And some states have a reasonable physician standard. What would a reasonable physician say? At a practical level, as a physician, I can tell you we take into account both. What should I be telling you and what would I expect that you need to know? But the bottom line is you should really understand what you're undertaking. In this case, the allegation, as you'll see from some of the testimony that we'll hear from the expert, is that informed consent was given. The plaintiff seems to be making arguments, well, I didn't understand perhaps exact percentages, or could you tell me it was 11% or 3% or 49? I'm making up numbers. And the counter argument is informed consent often isn't that specific. Those are general statistics, but we're talking about you, and I can't say your risk is 7% or 19. I can just talk about general statistics, so they become less important. What's more important, is this extremely rare? Is it likely? What do we think we're going to encounter? So we'll see some things with that. But what's interesting is that when a patient makes a claim that you as a physician have done a procedure to them to which they did not consent, that's where a totally independent tort of medical battery can arise. And battery, we see it occasionally brought up. There are some strategic and tactical implications for it. Battery may not, for example, be constrained by medical malpractice caps. So California, notoriously under MICRA since the mid-1970s, was at $250,000. But if you have a battery claim, that would not be constrained necessarily. So there's a lot of interesting things in here, but that would be just some foundation of what we're going to get into today.
Right, right. And that is fascinating. On a base level with informed consent specifically, you might think at first it's kind of a battle of the documents. The patient signs the documents giving consent. They have, certain risks, benefits. But beyond that, you have this discussion, this very personal discussion with the doctor in the exam room. And that's where this testimony really centers on. And with that, we'll get into one of the main defense experts in this, Dr. Bob Carter, who is actually a professor of neurosurgery at Harvard Medical School and practices at Massachusetts General Hospital. And he'll be talking a little bit about those discussions and standard of care regarding those discussions and how sufficient they should be. With that, we'll get into the first clip. Let's take a look.
Talking about the facial nerve, that's what we're talking about. How detailed do you get in that discussion about the risk relating to the facial nerve?
We usually try to highlight the fact that there is a risk in the immediate period after the surgery because of the fact that we've been in there manipulating near the surgery. That risk is higher. We also talk about the long term, which is, say a few months or a year after surgery. Most patients are focused on the long term. They're willing to undergo some potential transient problems to get the tumor out and prevent the other problems from the tumor itself. So we talk about the facial nerve in that way. I would say, in my experience, in my practice, it's an unusual thing that we get into, like the literature or papers or things like that.
All right. Do you talk specific percentages?
Generally not. I usually counsel patients in ranges. I'll say something like we have if we have a patient with a tumor of a certain size, I might say, well, listen, I think the risk of a permanent facial problem here is in the low single digits. I'm not going to say 3% versus 4% or something like that. I'll just try to give them a range.
All right, and with this, you saw the size of this Mr. Pullman's tumor when he was seen by Dr. Schwartz, correct?
Yes.
If you were going to give a specific range, if a patient says, "Give me a range, doctor," what would you have told him?
Objection. Sustained with. Overruled. No, I'll allow that question. He's testifying as an expert in what advice is appropriate. You may answer.
Yeah, I would have said, Mr. Pullman, we're likely to have a situation where, after surgery, you would have a reasonable percentage chance of a temporary problem that's going to last potentially a few weeks, maybe into a few months. The risk of a permanent, severe problem, low single-digit percentage.
When you talk about a permanent problem, what time period do you?
Usually about a year. It takes, for example, after a surgical procedure, it takes about a year for the nerve to fully recover, essentially.
All right. And obviously, if they ask you questions, you're going to respond to their questions.
Correct.
Have you had patients indicate, "I want a specific percentage"?
No, because I don't feel like I can necessarily give them a very specific percentage in the sense that every patient's a little bit different, and the literature is really just an embodiment of the collective of many patients. So I like I said, I try to go with a range.
So that was interesting in how he broke down the limits of informed consent there and the information that he gave. What are your thoughts on that initially, Dr. Bentley?
A couple of thoughts. So remember, that's Dr. Bob Carter, professor in chief of neurosurgery at Mass General, which is essentially Harvard. So arguably one of the greatest living neurosurgeons. And he's saying, I can't give you an exact percent. That's pretty compelling. The other thing I like with him, he just looks like a nice guy. He's there, he's talking to the jury, seems very gentle, very professional, very honest. So a great appearance for an expert who's just there to really tell the story. So in the battle of the experts, that's a pretty good horse to have. Again, what he's saying is, I can't give you an exact percent. The attorney, though, pushed further and got him to say, I would imagine some people might have some temporary weakness, weeks, months, but low single digits on permanent injury. So we should think for a moment about what that means. So if you are the plaintiff attorney, you might be salivating for a moment going, well, wait a minute, Dr. Carter, you just said low single digits, 1%, 2% chance. Why is Mr. Pullman's facial nerve severed? I mean, sounds like this shouldn't happen. So remember, statistics are statistics. They can be played either way. So we want to be very careful. Whether it's 1%, whether it's 10%, that doesn't tell us which ones of those occur as just a natural result or maloccurrence, and which occur from malpractice. So that's always something that when we're working with experts, make sure that if we're going to get into precarious statistical tendrils, that we're ready for those questions on cross. Well, doctor, you just said 1%. How do you explain why this happened? So always remembering any complication, is possible: bleeding, infection, death, but which of those occurred from malpractice? So that's probably just my summary view on what he said, and I think he did a good job tackling those questions.
Right. One of the things that I noticed was he went a little farther, and the defense attorney there, Mr. DeHaas, went farther in first asking about whether the doctor gave percentages at all. And the doctor said, no, I give ranges. I believe in giving ranges. And then he went a little farther and said, well, have you ever had a patient that's asked for a percentage specifically? And he wasn't explicit in it, but the implication was that if a patient asked, he would not give that specific percentage, that he preferred ranges. So it went beyond just, I typically don't do it, to implying that I will not give a range to a patient, or I will not give a specific number to a patient, because every patient's different. And I thought that was very strong there. The other thing that I thought was very strong that he did and really enhanced his credibility was, at one point, he goes beyond being an expert on the witness stand and almost channels himself as the physician speaking to the plaintiff. When he's talking to the jury, he says, I would say, Mr. Pullman, you have X, Y, and Z. These are the risks and benefits, X, Y, and Z, as if he is the doctor himself. And I thought that really enhanced the credibility, really connected with what that testimony was. What are your thoughts on that?
So you've got a great eye for that. So we're always looking for the tangibles and intangibles, things we can bring forth from our experts. From the simple things, eye contact with the jury, speak to them like you could be their physician, avoiding, jargon and terminology that's going to be over their head. But a very nice stylistic point that he did quite naturally is just dropping into that physician's role. Because what is his ultimate role as an expert witness? It's to decide what a reasonable surgeon would or would not have done to Mr. Pullman, to the plaintiff, what should have occurred. And he essentially steps literally into that role. And I think it really crystallizes it. And again, when that's done with knowing who he is, that's not just some paid expert showing up, that's the expert on point for this surgery. I found that very, very compelling as well.
Right. And just as a note, a little side note here, the defendant physician as well is very well regarded in acoustic neuroma treatment and in this particular translab procedure. So there was a little bit of a high hurdle that the plaintiff was facing, bringing this claim against that particular defendant, and then having this defense expert as really the primary expert in that case.
Well, and again, you've brought up a good point. Here we are deep into trial testimony, but before we ever get here, how are we teeing it up? And again, Battle of the experts is how we always approach it. In this case, you've got battle of the defendant surgeon. So Dr. Mark Schwartz, very well known professor on the faculty of UC San Diego right now. And when this case occurred, he was at the House Institute, which is a very renowned West Coast Institute for Otolaryngology and complex tumors, just like in this case. So he's a big fish. And then he's got about the biggest fish in the United States defending him. So if you're teeing this up from a plaintiff perspective, those are things you've got to know, because if you're not matching things up right, you'll get decimated. So I don't know all of Dr. Carter's testimony or Dr. Schwartz's, for example, but they may have done this surgery thousands of times. And if you pull in an expert who goes, oh, I've done 29 of these, the scale's not going to tip in your favor. So again, how you carefully tee things up before you ever get to this point is critically important.
Right, right. And because this issue of informed consent is so important, we'll take a look at another bit of testimony from Dr. Clark here on that informed consent issue.
So we've been talking about informed consent. Did you form an opinion if his informed consent of the patient complied with the standard of care?
Yes, I have.
And can you tell the jury why, in your opinion, it complied with the standard of care?
Yeah, I think from my perspective, the patient and Dr. Schwartz obviously had a number of conversations. So it wasn't a short, fleeting interaction, but rather it was an interaction that was sustained and occurred on multiple visits. In addition, the patient had seen other providers, and Dr. Schwartz was aware of this, and so there was an interaction to understand that the patient actually had some level of research here and had been able to explore the different options. Dr. Schwartz at deposition and in his notes talks about the different strategies and alternatives here. I understand that there's a dispute between the witness and Dr. Schwartz about some aspects of that, but from my review, I felt like it complied with the standard of care.
I felt like that was a really good summation of his thoughts and conclusions on the standard of care. Dr. Clark gave testimony on a number of issues touching this trial in this case. And so I think it's important in these type of cases and with this testimony where it's so complex to kind of take a step back and at the end of each chapter, at the end of each issue, sum those up. What are your thoughts on his summation there?
I think it was very focused and to the point, and it's a key issue in this case. Either complied with or departed from the standard for getting informed consent from the patient. And Dr. Carter's emphatic. I looked at the consent and it complied. Presumably that's what Dr. Carter would have done with his own patient. He also adds that something you mentioned at the introduction, this was a bit more of a sophisticated patient perhaps than your average patient, because he had sought other opinions and really understood it, knew about risks. That brings out a nuance in informed consent. We talked about the reasonable patient standard, what would a patient want to know, or the reasonable physician standard, what would a physician say? There's a third standard that we don't really use, but sometimes called the subjective standard. And the subjective standard means, what would this patient want to know? Like, for example, let's say I'm doing the surgery on Dr. Carter. Okay, well, Dr. Carter probably knows more about the surgery that I'm about to do to him than I know. So what would I have to share with him? So I think what Dr. Carter is essentially saying in that is, hey, this patient knows a lot. He's been around the block. I haven't let my guard down. I'm still giving a compliant consent, and he's a smart guy as well. We've covered everything. It also comes back to the importance of documentation. What was in that documented informed consent? I'll see ones where it says, patient understood risk, benefits, and alternatives, agreed to proceed. That works great right up until the moment it doesn't. So really in informed consent, you should document what you told the patient. And remember what happens in a lot of one-party consent states. Patients have their iPhone or Android, I guess on rare exceptions, in their pocket, and they're often recording what people say. So we've had a number of cases come up in one-party states where that's legal, where unbeknownst to the physician, a patient's recorded that entire session. So I think it behooves physicians just be compliant, not only do the correct informed consent, but document it as well.
Right. And to your point on that, I liked how Dr. Carter acknowledged the dispute kind of at the heart of this informed consent. It was a little bit of he said versus Dr. Schwartz versus the plaintiff as far as what was discussed there. And Dr. Carter very much was emphatic in saying, from my review of the records here, I understand that there is a conflict of what was said, but I believe that sufficient information was given in this case.
Yeah, I think that that's nice. An expert, to your point, is not the trier fact. The jury is. So he can say, based on what I'm seeing in this informed consent, it's compliant. By the same token, he can take into account what the plaintiff may have said and said, gosh, if indeed he really wasn't told anything and Dr. Schwartz and everyone in the room, no, that wouldn't meet the standard of care. So we can sort of consider both as a hypothetical, but I like how he doesn't touch the third rail and say something like the plaintiff is crazy and making this up because I'm reading what the chart said. That's not his role. And again, that's something we're always counseling experts on and kind of the lead up to this. Remember, if there's an issue, two sides to this, he said, again, your job's not to decide who's telling the truth, but your job is to guide considering either hypothetical or based on what we're objectively seeing in evidence.
Right.
Yeah.
Now, moving beyond informed consent to the actual surgery itself, the surgery was recorded, and that served to be a big part of the trial with evidence surrounding the video recording of the surgery. We aren't going to play a clip of the video recording of the surgery or of Dr. Clark walking in the defense through that surgery and commenting for jurors, but we are going to play the next clip, which is him summarizing his conclusions surrounding the surgery and what he thought might have caused this facial paralysis. So let's take a look at that now, and then we'll discuss.
Do you have an opinion as to when this injury occurred to the facial nerve?
Yes.
And what is your opinion?
That occurred outside the time frame of Dr. Schwartz operating on the patient. That is to say, before Dr. Schwartz operated on the patient.
And why do you say that?
After my careful review of the video, I looked for common causes of why the facial nerve could be injured at the time of microsurgery. Those would include things like dissection along the nerve or alterations of the blood vessels, or, for example, coagulation of a large blood vessel that was going to the tumor, or things like that. Unusual stretching of the nerve or anything, and I didn't see any of those things. And I also know that in my own experience in patients that I've treated, I've had patients who, in the drilling process itself, have had injury to the nerve. And it's well documented in the literature that heat transfer can occur and can cause injury to the nerve. Now, a person might ask the question, why do you get a signal if there has been an injury to the nerve? Well, remember, you only get the signal distal to the site of injury. So if the injury occurs at point A, past that point, you'll still get a signal, but in front of that becomes the blocking zone. And so in my opinion, based on the review of the video, I didn't see anything that looked like it would cause a nerve injury during the microsurgical portion of the case.
All right.
That was an interesting summation there. What are your thoughts on that, Dr. Bentley?
So a couple of things to unpack, and let's stay away from too many of the technical elements of the surgery because we aren't covering that as much today. But the first to me is, why is there a video? So I don't know whether that occurred to some people in the audience today, but you're going to see more and more videos, or the potential for videos, as we have more and more intraoperative video recording. So we have this capability now as surgery has become minimally invasive, robot assisted, other methodologies. So there's a lot of recording going on in the operating room. So the question is, why don't we have videos on every single case? It turns out, and this is going to be state specific, there are times when you can and can't get video recordings. It depends on how it's designated. Is it done for teaching purposes, internal, quality control, peer review? It may be entirely barred and restricted. If it's done as part of a medical record and routine videography, it may indeed be available. So it's something to always request and be mindful of. What we see in a lot of plaintiff cases is overt excitement. Oh my God, there's a video. This is incredible. In this case, the video saved the defendant physician. So when Dr. Carter goes through it, he's watching the entire surgery and basically said there's no breach. So remember, just because there's a video doesn't mean you've got the smoking gun. It means you've got another piece of evidence to incorporate in the case. I always want to put that out there. But forgetting to check for a video can backfire on either side. So it's really something you have to be aware of if it's present. Definitely look for it nowadays, but certainly in complex surgery, neurosurgery, this happens to be otolaryngology or skull-based surgery. Videography is pretty uniform. So I think that's an important point to make. The other thing that I really liked that Dr. Carter said, I mean, imagine, world famous neurosurgeon, he goes, same things happen to me. I've had cases where that nerve got hurt. That's pretty powerful. Did Dr. Bob Carter of Harvard malpractice? No, what he's saying is there are factors in the due course of brain surgery where someone can get hurt. So he's saying, I've just been drilling through a bone where the bit heated up the bone and that heat transfer was enough to hurt the nerve. There was a thermal injury, not malpractice. It just happened. So I really liked that. It was a subtle point. Had I been the attorney on direct, I might have said, wait, Dr. Carter, can we back up a moment? You're saying this has happened to you? This similar type of thing? There might have even been a chance to have really resonated with that. So medicine, again, art and science, not a guarantee of perfection.
Right. And I thought he did a very good job in explaining how that might have happened, not in this particular portion of the surgical procedure that this defendant physician was involved with, because that seemed to be the, kind of, if you think about it common sense wise, well, there was facial paralysis. When else could it have occurred? And he indicates very clearly this occurred before this portion of a multi-part surgery, a multi-part procedure, before the portion of the defendant surgeon.
Yes, a multi-part surgery where the first part of surgery, opening the skull, was conducted by a different surgeon. Wow. So in other words, it was they're cutting that piece from the defendant in this case, Dr. Mark Schwartz. They're saying another surgeon did this first part. That's where the nerve got hurt. And Dr. Schwartz is now so deep in there in a different part, he's not going to have any idea that this occurred. And remember, that's what goes back to this whole battery construct in this case. The plaintiff is saying, hey, on my informed consent, if you think you've hurt my facial nerve, I got to have you just stop. That's like the one fearful thing. I don't want to have it. What Dr. Schwartz is saying, I had no idea the nerve was hurt before I ever got there. And the plaintiff argues, well, you were supposed to be testing the nerve. And had you been testing it right, you would have known this nerve wasn't working. And what Dr. Carter, the expert, and Dr. Schwartz, the defendant, both say is, wait a minute, the nerve was cut at a different part further out when the first surgeon removed the skull. I'm testing a deeper inner part. And each time I test it, that part of the nerve is working. So in other words, they're taking apart that informed consent issue, which is the battery issue. I told you to stop if you think my facial nerve is hurt. Dr. Schwartz is saying I had no idea it was hurt. So that gets rid of the battery part. And then the rest of it is just attacking standard of care. Exactly.
And to your point on how surgical video really can cut both ways, no pun intended, the defense there, it really did aid the defense, and particularly with how Dr. Clark walked jurors through that video. There's a portion, it all comes down to whether Dr. Schwartz was testing that nerve for a signal to see if it still had a signal. During the video, at different times, Dr. Clark is going signal, signal, signal. See, he's getting a signal right here, right here. It's like an exclamation point again, again, again for the jury as they're watching this video with him. I thought was really impactful there. But turning to video more in general, there are a lot of advantages to it if you can get it in, but also a lot of pitfalls in potentially turning off the jury because the video can be so graphic. Could you address a little bit, talk a little bit about how to avoid those pitfalls and maybe avoid turning off the jury and getting them to kind of avoid them disconnecting from that portion of the evidence?
So I look at it pretty broadly. In fact, in a bit of an informed consent context. What are the risks and benefits and alternatives to showing that video? And I think that's a really good way to think about it. If it's just unnecessarily graphic, if you've already done the heavy lifting, momentum's on your side, and there's a chance this could backfire. You could make a jury visibly nauseous. It's not going to move the needle. I'd advocate against it. There's, 3D animations, poster boards, PowerPoints, whatever you want to do are alternatives to overly graphic video. Now, there's lots of times we want a graphic video to make a point. In this case, it really wasn't about a point. This is such a complex neurosurgical procedure going on in the brain that they are so deep in there that I'd argue most physicians who would watch this video wouldn't know what they were seeing. It was literally parts and pieces in every direction. And Dr. Carter's doing a good job trying to orient people. Truthfully, I'd have to see it in the broader context to know whether I would have advocated showing that because it was so graphic. But to your point, Dr. Carter was just trying to say each time the nerve was tested, it was working. Plaintiff, your whole argument is the nerve was out and we should have known. And here we are, test, test, test. And that's the classic thing. You can only imagine when the plaintiff found out there's a video, they're excited beyond words because that's the smoking gun. Yet that's the gun pointed at them that just undid their case. The surgery looks like it fully complied with the standard of care.
Right.
Yeah.
And I love your analogy on using it as informed consent with the jury. And jurors on leading up to showing that video. I think that's so important from voir dire onward to let them know a video might be shown, kind of suss out any jurors that would be extremely uncomfortable if you have to use it, and then only use what you necessarily have to show to make your case. And particularly with presentation, I thought Dr. Carter, that's where he pulled out his professorial cap and really walked the jury through like they were students. And he was very academic about it. He was very emphatic about it, but also didn't make it overly dramatic. It was very, calculated in what he was saying. And he moved through very quickly. He got the job done without spending too much time on the issue, which might disconnect jurors as well.
And that is one of the reasons I really love university experts. There's always this mistaken notion, well, if they're a professor of surgery, they're not a doctor, or they're not operating, or they're just writing books. Professors of surgery and medicine as well can be fully clinical or substantially, and 80% of their time can be clinical. Dr. Carter is in the operating room every single day. So the fact that he's in the trenches doing the procedure, but that he is an academic, meaning he can teach, he can explain, he can articulate verbally and in writing. That's how you convey a case. And so I am a big proponent of university physicians and surgeons. And again, he did a great job. Not everyone in the private sector or academia is as just, congenial as he is. I mean, he really looks like someone, gosh, if I have to have neurosurgery, I want to call Bob. He really carried himself well each time, again, turning, talking to the jury, really like he was speaking to them in a patient's room. And so I did appreciate his style.
Right. Now, as you mentioned, it does come down to the battle of experts here. And one thing the doctor does is address the plaintiff's expert and his conclusions. We're going to take a look at that clip now, because that, I think, was really important.
You reviewed, have you not, the testimony given in this trial by Dr. Bloomfield, correct? Plaintiff's expert, one of their experts?
Yes, I have.
And do you find in reviewing his trial testimony any glaring errors made by him as far as his opinions?
I found a point that I disagree with.
And all right, will you tell the jurors the point you disagree with?
Dr. Bloomfield described 2 hard stops during his surgery. Hard stop number 1, which was, the initial stimulation of the tumor capsule, and then he described hard stop 2, which is more down around the entry zone, and the idea that that would cause Dr. Schwartz to limit the surgery. Hard stop 1 doesn't really exist. You saw in the video, to get into the middle of the tumor, to deflate it, you actually have to stimulate, and it has to be negative in order for the surgeon to have the confidence to go into the middle of the tumor. If the signal is positive there, that's when you would stop the surgery. But Dr. Bloomfeld was saying that you'd stop the surgery if the signal is negative. It was not logical, and I disagree with it.
All right. Anything else that Dr. Bloomfield said that you disagree with that you can recall?
I don't recall all elements of his trial testimony, but certainly that was the main thing.
All right, what did you think about that conclusion on the plaintiff's expert and how he addressed the plaintiff's expert's main point there?
Yeah, so I think on this, again, I'll take the technical element away from it and focus on his words. So his attorney gave him an opportunity. Did you see any glaring errors? And Dr. Carter actually downplayed it a little bit. Well, there is a point of disagreement. That would be something I'd work with an expert a little bit more on. And I'm a fan of Dr. Carter, but I'd work with an expert a little bit more. You're in court for a reason. I mean, this thing's been going on for years, and today's the time to tell your story. And when someone's saying there's two experts in the courtroom, I'm presuming you guys have opposite opinions. Tell me what's wrong with the other one. That's your chance to really articulate it. So the style change, I didn't really like as much. I'd like it to be more emphatic. Here's where the other expert's wrong, or here's where I absolutely disagree, or here's where I'm at a loss to understand what the other expert's saying, and then make that point. The other thing is when the attorney said, are there any other points with which you disagree? He said, and I'm just paraphrasing, was something like, well, I don't recall all of the points he made during trial testimony. At that point, you need to recall the points during trial testimony. So it's your last chance, literally and metaphorically, to speak to the jury, to rebut the opposing expert. You've got to have locked that down. So that came across a little soft in it. And again, that's beyond all the technical details. They're talking about, whether they got signal and where the facial nerve was, and I won't even go there. But the opposing expert was saying, there's a couple points where you could have had a hard stop. A hard stop means surgery's done. We don't cut further. We're at risk of injuring something. So the plaintiff's theory again, hey, you should have realized the facial nerve's in trouble. You had two opportunities for a hard stop. You blew through the stop sign. So again, Dr. Carter's saying that's not true. You've actually misinterpreted it, but that could have been a bit more practiced. When we're working with legal teams, our goal is to get ahead of those points. Dr. Carter might not have known that question's coming, but the legal team knows that. So you work with experts. Hey, let's go through this. Let's do some kind of direct role play. These are questions I'm going to ask, but let's also do some adversarial role play. Let me ask you some precarious questions you might be scared of. But to be a bit more polished on such, what could be the bullet point. And remember, juries are a lot about TikTok, sound bites, Instagram, they want to get their fix and go on to the next recipe. If you've got a chance to really make a point and drive it home, and Dr. Carr's about to say thank you and step down, let's stick the landing a little better.
Yeah, and that makes a lot of sense. I know at one point there, he said something to the effect of the plaintiff's expert's conclusion is illogical and I don't agree with it. But there was a lot of equivocation before then. So it sounds like what you're saying is lead with that point and then follow up with that point later on as well. Is that right?
Yeah, equivocation, I think, is what we were both feeling. And remember, this is a defense verdict. They won. They're on the right side of it. Video supports it. Dr. Carter drove it home. I'm not here to be critical. These are just high-level style points because remember, with the jury, 50-50, it goes the other way. So you really have to tee things up for success right out of the gate.
Right. And to that point, I think summing up again, like we talked about, taking that kind of chapter summary at each issue really does help. So I did like how he did that at the end of this walkthrough of the video. I thought that was timing wise very appropriate there. Could you address those summaries and the best time to make those throughout testimony?
Well, we've seen that in other CVN videos where there are beautiful bullet point summaries at the very end and sometimes having an expert go through it. That's sort of what I was alluding to. It's the time to drive it home, not to equivocate or be soft or have too much of a concession. So bullet pointed summaries at the very end. So Dr. Carter, as we prepare to wrap up, I want to make sure I understand all of your opinions and that the jury does. Let's go over this slide. And, we've seen that, and you and I have done a video on that where there was beautiful bullet points. That might be a great chance to go through it. In this case, informed consent was actually correct, compliant the way you would have done it. This is a known risk of this surgery, right? Just because it occurred doesn't mean it's malpractice. In this case in particular, it looks like the injury occurred before Dr. Schwartz ever got in there, and that's something that's known to occur. And on and on. And by the way, the other expert is incorrect because he said X, Y, and Z. I mean, and that's just for me gleaning it from watching, bits of video. Maybe there's 12 bullet points. And then knowing how to put those in the right order and right emphasis so that the sound bites are sticking with the jury as they walk away.
Right. Well, this was a fascinating trial, and ultimately, as we mentioned, it led to a defense verdict. Plaintiffs, I believe, sought $120 million in damages there. So large stakes, high stakes case that led to a defense verdict. And key to that was this testimony, which overall was fantastic and very well presented. Any other thoughts on this and these type of claims, whether it's informed consent or medical battery cases? What are your thoughts on those just in general as we wrap up?
I think we've covered it, but it's just doing the homework, making sure that you're not leaving anything unturned within a case, whether you're plaintiff or defense. You don't want to be exposed. Again, when we talked about intraoperative video recording, informed consent, allegations of battery. So making sure you've not left anything unturned. And by the way, for our audience in the show notes, we'll put a couple of links, one to informed consent that'll highlight a lot of what I spoke about today, patient standard, physician standard, subjective standard. But there's also a case we handled recent from about 2020. It went all the way through California appellate courts, but it's a case where ended up going to jury, $9.25 million from what looked like a med mal, which would be capped at $250 in California, but it went for $9.25 million because it evolved into a battery claim. So if you really want to look at the anatomy, it's a case called Burchell v. Faculty Physicians, and again, we'll throw that in the show notes today. Pretty fascinating case, and again, brilliant work by a plaintiff attorney in California in parsing that out early on in what appeared just to be a med mal.
Definitely. We'll have that in the show notes. For sure. Well, Dr. Bentley, I want to thank you for joining me again today. It's been a fascinating discussion on this, and it's like we said, it's kind of an uncommon procedure, but the issues at the heart of it really are common, and you see them a lot in trials. So thanks for joining me today.
Enjoyed it. Thanks for having me. Take care.
And thank you. Take care.